Hemos depurado este año un poquito más. Está activado. Pero pasan con retraso. No pasa, ¿eh? Muy buenas, aquí estamos de nuevo en ARI 2022, en este marco intemporal en el cual podemos, cualquiera de vosotros y nosotros, atender a estas sesiones en el marco que deseemos y en el momento en que podamos. En este marco tenemos ahora esta sesión 4, en la cual vamos a hacer un estudio y una puesta en evidencia de cómo podemos evitar la queratoplastia. José Luis.
Bueno, seguimos y tenemos un panel interesante, muy interesante que hemos seleccionado. Recordar que además después tenemos un ratito de discusión, de nuevo con Nicolás Alexandre, Jorge Arío del Barrio y Ana Boto. La primera, vamos a hablar de diferentes alternativas a la queratoplastia convencional. Y la primera, un overview importante que nos va a dar Jorge sobre si son buenos los resultados de la queratoplastia o cuán buenos son.
Gracias, José Luis. Y antes tenemos un mensaje de la industria de parte de Topcon. Adelante. Buenos días. En esta sesión cuarta de ARI 2022 tratamos de si se puede evitar la queratoplastia y qué alternativas médicas y clínicas existen a la misma. Dentro de este contexto se encuentra esta presentación en la cual nos preguntamos si los resultados de los trasplantes de córnea son hoy suficientemente buenos. En España se realizaron en el periodo del 2001 a 2016 casi 50.000 trasplantes de córnea, según la Organización Nacional de Trasplantes. El progresivo envejecimiento de la población, la existencia de más números de cirujanos de córnea y de centros realizando trasplantes han creado una demanda de más tejido corneal, y la introducción de nuevas modalidades de trasplante de córnea han llevado a nuevas indicaciones. Sin embargo, los fracasos no son raros. Los fracasos pueden ser de dos tipos: anatómicos, en los cuales hay una pérdida o una inadecuada transparencia del injerto, lo cual constituye un fallo del tejido, pero existen muy frecuentemente fracasos funcionales en los cuales no se alcanza una agudeza visual suficiente que puede cualificarse como un fallo del resultado. Este artículo es el primero y único que se ha realizado en España en el cual se ha realizado de un modo multicéntrico un estudio acerca de los fracasos del trasplante de córnea. Este estudio, que fue coordinado por la Red Nacional de Investigación Oftalmológica Corporativa, OftalRed, bajo mi dirección, y que fue realizado por Alba Gómez Benjós de la Clínica Barraquer, puso en evidencia los problemas que tenemos en el medio plazo, a 5 años, con la pervivencia de la función o de la transparencia de los trasplantes de córnea. En general, se pudo detectar que la queratoplastia penetrante tiene de un 20 a un 30% de fracasos anatómicos a los 5 años, las queratoplastias anteriores lamelares de 2 a un 5% y las queratoplastias lamelares posteriores de SAEC o de MEC de un 2 a un 5% según los centros. Las causas de los fracasos anatómicos eran, en primer lugar, el fracaso del injerto, como vemos aquí, más frecuentemente en las lamelares posteriores y menos frecuentes en las queratoplastias penetrantes. El mayor riesgo para estas últimas, las penetrantes y los reinjertos, es el rechazo inmunológico, que con mucho es la primera causa de fracaso anatómico en estos dos grupos de queratoplastias penetrantes, seguido del fallo endotelial tardío, que ocurre en todos los niveles, pero sobre todo en la casuística analizada en las de SAEC, del glaucoma asociado al posoperatorio, que constituye una lacra de esta cirugía, y de las enfermedades de superficie ocular que afectan en particular a la queratoplastia lamelar anterior, como vemos aquí en la imagen. En conjunto, tenemos que existen unas causas identificadas de fracaso que pueden sumarizarse en causas primarias: rechazo inmunológico, fracaso endotelial tardío, glaucoma y enfermedades de superficie ocular, entre otras, inmediatamente después seguidas de recurrencia de la enfermedad inicial, sobre todo en aquellos casos en los cuales ha habido un herpes previo. Este trabajo es clave para entender cuál es la situación actual del trasplante de córnea en España y, repito, es un trabajo importante que se realizó desde Oftalred, en lo cual hemos puesto en evidencia que los estados de trasplante de córnea no son satisfactorios hasta donde nos queremos. Este estudio fue repetido a nivel monocéntrico por ver si se trataba de un problema general o de un problema que afectaba solo a algunas clínicas. Y pudimos ver en este estudio, sobre casi 1000 trasplantes realizados en Viso, en Alicante, que las causas de trasplante de córnea y de su fracaso eran aproximadamente las mismas que en el estudio multicéntrico español. Pero cuando analizamos la casuística en este análisis temático a nivel mundial, en este trabajo que publicamos en British Journal of Ophthalmology, pudimos comprobar que es un problema global. Se trata de, casi en todos los casos, de modo repetitivo, de las mismas causas que llevan al fracaso de los trasplantes. Por tanto, tenemos el fracaso del trasplante como un hecho relevante. En el caso de la queratoplastia penetrante, el fracaso es refractivo o por problemas de superficie ocular, de glaucoma o pérdida de transparencia, además de los anteriormente mencionados anatómicos. Estas son causas funcionales. En el caso de la queratoplastia lamelar anterior, las causas de fracaso funcional son las mismas: refractivas, problemas de superficie ocular o glaucoma o mala transparencia del injerto. En el caso de las de SAI o de MEG, solamente para las de SAI se detectó una pérdida tardía de transparencia debido a la pérdida endotelial progresiva con pérdida de función, lo cual es una forma híbrida de fracaso anatómico y funcional. Como vemos en estos trabajos de otros autores, hasta el 30% de los trasplantes que son anatómicamente exitosos, tanto penetrantes como TAL, acaban con una agudeza visual corregida menor de 0,4, lo cual es subóptimo. Es evidente de que la queratoplastia penetrante ofrece, por razones que no están claras, unos resultados en las series superiores a la DAL, aunque desde luego la DAL tiene menores problemas inmunológicos. Por tanto, podemos responder a la pregunta de si los resultados de los trasplantes de córnea en el año 2022 son todavía un problema. La respuesta es que sí lo son. Necesitamos optimizar los resultados anatómicos de los trasplantes modernos de córnea. Debemos de abordar las principales razones de fracaso, que son el rechazo inmune, la inflamación de superficie ocular y el ojo seco y el glaucoma. Y evidentemente existe una necesidad de buscar nuevas soluciones basadas en modernas aproximaciones terapéuticas, tales como las terapias avanzadas, el uso de células madre para la regeneración corneal y evitar la sustitución de tejidos. Este libro, que publicamos hace ya 3 años, en el cual abordamos las técnicas de regeneración corneal, explica bien esta tendencia, que es lo que lleva a esta sesión de ARI a abordar estos temas de cómo evitar la queratoplastia con técnicas alternativas. Nada más y muchas gracias por vuestra atención.
Gracias, Jorge. Vamos adelante.
Muy bien. Pues muchas gracias. Ahora Alice Davidson nos va a presentar una charla sobre la terapia génica en enfermedades corneales, que es una opción para el futuro.
Hi, my name's Alice Davidson. I'm a researcher at UCL Institute of Ophthalmology in London, and today I'm going to be talking about gene-targeted therapies and their applicability to inherited corneal disease. So what do I mean by the term gene-targeted therapy? I'm using this term in the talk today in its broadest sense. So I'm using it to describe any type of therapy that aims to target the genetic cause of a given disease and either reverse or delay its symptoms. When we think about this category of therapies, it's important to point out that they can actually act at the DNA or the RNA level. So classically, we think of gene therapy as being a gene replacement, viral-mediated type of approach. The classic example here would be Luxturna, which was in fact the first FDA-approved gene therapy to treat any type of human disease, and it's been used in the treatment of LCA, Leber's congenital amaurosis. But as the field has progressed, a whole host of new therapeutic options are emerging. At the DNA targeting level, these also include binding small molecules. So as their name suggests, these are molecules that bind DNA to modulate downstream transcription, as well as gene editing technologies, which actually have the ability to edit DNA directly. At the RNA level, we will have another whole class of approaches and molecules that can be, in theory, used to treat inherited disease. Antisense oligos, these are synthetic nucleotides that can bind to RNA. Small interfering RNAs, or siRNAs, which are classically used to silence gene expression. And lastly, there is now a emerging RNA base editing technologies appearing, which have the ability to modulate or edit the RNA. So there's lots of options available, but to develop a gene-targeted therapy for an inherited eye disease, you need to have a prior amount of knowledge. So you need to understand the genetic cause of the given disease and the inheritance pattern. You also need to have a good understanding of what cell types are affected and the molecular mechanisms responsible for the cellular dysregulation. And on top of this, you really need to understand the natural history of disease, so the disease onset and how it progresses over time. Once you have this information, you're in a position to consider thinking about designing a gene-targeted therapy. So why should we think about this for inherited corneal diseases? So as you probably know, there are currently no preventative treatments for this group of conditions. Transplantation, corneal transplantation is currently the gold standard of treatment for patients, but we know that there's a global shortage of appropriate donor tissues, and on this basis alone, there's a real clinical need for new types of therapies to be developed. Not only that, the cornea is actually a great model system to work with due to its ease of access and also the immune privileged state it has. And this means that therapies can be developed within the cornea that have the potential to go on and influence the design and development of therapies that could treat less accessible conditions. And lastly, I just want to point out to you that although individually rare, collectively inherited corneal diseases are common and they are posing an increased societal burden. Here I have summarised for you the list of known inherited corneal diseases that have been classified to date, and when I identified the underlying genetic cause. The reason I'm showing you this slide is because I want to be able to convey to you how both genetically and phenotypically diverse this group of conditions are. Why is that important? Well, when you think about gene therapy, that's very important because each one of these conditions has a different genetic cause with different underlying groups of mutations and different molecular mechanisms underlying the disease, and they all affect the cornea in different ways. So you have to factor in all these things to design an appropriate gene therapy for each respective condition. And on this basis, of course, we have to individually design these therapies on a case-by-case basis. So I'd now like to walk you through an example of experience from my research group on going about to develop a gene-targeted therapy for Fuchs, which is in fact the most common form of inherited corneal disease classified to date. As most of you know, this is an age-related disease that primarily affects the corneal endothelium, so the innermost layer of the cornea. We know it's a genetic condition, and fascinatingly, up to 70% of patients with this disease have the same genetic cause, and that's expansion of a CTG repeat element within an intron of the transcription factor encoding gene TCF4. We've performed lots of research in my group to really try and work out the cellular hallmarks of this disease and the molecular mechanisms underlying the pathology. To do this, we've used primarily cells that have been derived from patients and grown in the lab, so primary cell cultures. And using this system, we've been able to define molecular hallmarks of disease. Here an example is these toxic RNA species that accumulate within affected patient cells. These are known to sequester RNA binding proteins, and the knock-on effect of that is you get a global disruption to splicing. So we now understand that RNA toxicity is really key to the pathophysiology of this condition. And on this basis, partnered with a company called ProQR Therapeutics to select an antisense oligonucleotide approach to think about treating this disease. Now, the ASO we applied acts via steric hindrance, so it just binds to these aggregated RNA species that accumulate within patient cells. And our proof of concept data within our cell system has demonstrated that treatment of cells with this antisense oligo can actually alleviate these features of RNA toxicity. And using this preclinical data in combination with safety data, ProQR were actually able to gain approval from the MHRA to run a clinical trial to test efficacy and safety of the antisense oligo. Unfortunately, this trial has recently been suspended, not for reasons to do specifically with the trial itself, but just due to the financial situation of the company. But nonetheless, I think this is still a great exemplar of how we can begin to think about using an antisense or an RNA therapeutic to treat an inherited form of corneal disease. And we hope in future we will continue to develop upon this idea. Now, I don't want to only talk about RNA therapeutics. I think it's also important to highlight that for Fuchs, for example, we could also think about targeting DNA directly, either potentially through using small molecules or via a gene editing approach, so using effectively what are molecular scissors to remove expanded copies of the repeat element. Moving forward, I think we're going to see lots of development at the DNA targeting level as well as the RNA targeting level, and more broadly at other mechanisms of pathophysiology, one example being somatic instability of the repeat length itself. So I think there's lots of exciting areas to look out for in terms of gene-targeted therapy development in relation to inherited corneal diseases in the short to medium term. I do also just want to end on some key challenges that lie ahead for the field. Really crucial is always going to be clinical trial to design. So whatever condition we're treating, we need to think very carefully about how we're going to be able to detect disease. In the case of Fuchs, we need to think about pre-symptomatic disease detection because it's age-related. We also need to be able to really understand the natural history of disease, and as I've kind of alluded to in my earlier slides, how we can identify biomarkers that we can then show efficacy and rescue of in a clinical trial setting. And of course, safety is always so important. We need to be able to target and deliver whatever therapeutic is selected in a really safe and effective way. Thank you for listening.
Well, thank you very much. Very interesting talk for the present and the future. And now is my chance to introduce my co-chair and friend, José Luis Well. He talked about regeneración del endotelio corneal, descending stripping only, con inyección celular. José Luis.
Hello. Thanks very much for the invitation. And thanks very much, especially to Professor Alio, for inviting me to talk about new therapies for endothelial dysfunction. So I must declare these red financial disclosures in this particular talk. So EK techniques is obvious that have significantly replaced full-thickness keratoplasty worldwide. And despite that, we still lack of long-term 10, 15 years data on this kind of surgery, today is the state of the art. Of course, there are some other therapies to substitute them that I think that are extremely promising, and I will focus on 3 of them. The first one is the synthetic lenticle, the EndoArt. Basically, is based, and this is one of the first operated cases by J. Offord, basically protects the aqueous humor to go inside the posterior stroma because it blocks it. So the surgery is quite simple conceptually. So what you do is to create a central rhexis, as you do in your standard EK procedures, leaving basically enough space to adapt this 6 millimeters in diameter synthetic lenticle. And then we introduce the lenticle as if it was the SAG surgery. Of course, there are several other ways to do it, but basically that's the most common way to work with. The second project that I want to talk with you is decimeter stripping only, the DSO or the WEC. The idea came from the mid of the last century. The first evidence of endothelial cell migration was published by the Kruse group. And we also have, obviously, indirect information regarding endothelial migration through these studies from the Meles group. Of course, there has been, this is a review of all the articles published about decimeter stripping only, and basically there are still some questions as to how we can select better the cases for this particular indication, the need of ripazodil or not, and the duration of the effect. What it was very well studied in this study from the Kinoshita group is that to use the ripazodil, you need to have a decimeter rhexis. If not, it doesn't work properly and have no interest in using it. So this was why the K321 COVA study was basically programmed. And these are one of the first cases operated by Professor Cruz in Erlangen, and these are a couple of cases that we did in Barcelona. So basically, the surgery is quite simple. You remove the central maximum 5 millimeters of decimet, and then the surgery is out. In the study, we were double-blind, of course, and some patients received topical ripazodil and some others received nothing. And basically, the results of the study, and that with decimeter rhexis alone and with the use of ripazodil, we were able to clear up significantly most of the corneas we treated. And the last one is cell injection therapy. This was the first study published by the Kinoshita group and showing how the technology should be applied. And this is the 5 years follow-up of the first 11 patients operated there with very good results in all the 11 cases. There has been some groups, especially one of the strongest is Aureon, who has been moving towards the use of this technology, and they account not only with the Japanese studies, but also in El Salvador. They repeat basically the study with very similar results. Of course, inside this cell injection therapy, there are several groups. Another very attractive one is those who are using, instead of culturing cells, they are using iPS cells to create endothelial cells, which still is in some way more attractive, despite that it looks like that cultural cells should work better. But this is something that is still under debate, and anyway, this technology, I think, possibly will become the more used in the near future. In summary, the MEC is today's gold standard approach for irreversible corneal endothelial deficiency. There are obvious potential clinical applications of these other described techniques, especially because a theoretical 13 million waiting patients are impossible to be covered by the most standard ones. Further improvements in the biological quality and of these techniques will still improve more and possibly substitute the standard techniques that we are using today. And from my point of view, genetic differentiation between cases in order to decide which is the best approach, and hopefully gene therapy, when indicated, will probably also have a strong role, as it will have in other corneal diseases. I just want to thank the kind invitation, but also remind you that the next EU Cornea Congress will be in Barcelona in late May 2023, and we will talk about these topics and many others. I would like and I love to see you there. Thanks very much for your kind attention. Y ahora vamos a tener una interesante actualización, la utilización del crosslink por uno de los más expertos en esta tecnología, que es Ingemar Gustafsson desde Suecia. Ingemar.
Good morning, everyone. My name is Ingemar Gustafsson. I work at the Skåne University Hospital and Lund University in Sweden. It's a great pleasure to be here today, and I thank you so much for this kind invitation. We will talk about how we optimize corneal cross-linking in clinical practice, and we will have the opportunity to have some questions and discussions after the presentation. And I thought of starting with the basic principles behind corneal cross-linking and then head on to the clinical aspects. If we start with the UV light, we can deliver the same amount of energy in a shorter time span or in a longer time span. And it shouldn't actually matter if we deliver this energy in 3 minutes or in 30 minutes according to the Bunsen-Roscoe law, because we deliver the same number of photons. However, preclinical data have shown that the faster the protocol, the less stiffening is induced in the cornea. This has also been demonstrated in randomized clinical trials. A higher fluence means a more shallow demarcation line and a lower stabilization of the cornea. The reason we induce fewer crosslinks and thus have a lower stabilization of the cornea with a faster protocol is due to the fact that the crosslinking procedure is oxygen dependent. Theo Saylor and associates have elegantly shown that we deplete the oxygen in the cornea with a higher fluence. If we have a higher oxygen concentration, we also get a higher cross-linking effect. So let's head on to the next ingredient, namely riboflavin. Most commonly, we use isotonic or hypotonic or HPMC-based riboflavins. Isotonic dextran-contained riboflavin is the most tried and tested riboflavin. However, it has the negative effect of reducing the corneal thickness. And we all know if we reduce the corneal thickness too much, we can damage the endothelium. For the purpose of maintaining the corneal thickness, hypotonic riboflavin was developed. And while it keeps the corneal thickness during the instillation phase of riboflavin, it can also lead to a corneal thinning during the irradiation phase with UVA. Its efficacy has also been questioned, and it could also have a lower shielding effect as it has a lower absorption coefficient. However, investigations have shown that it most likely induces the same cross-linking effect as isotonic riboflavin. HPMC-based riboflavin appears to give the same intrastromal concentration of riboflavin, and it also appears to keep the corneal thickness throughout the whole treatment procedure. Furthermore, the long-term results for using HPMC-based riboflavin appears promising. Let's also discuss transepithelial cross-linking. Transepithelial is commonly called epi-on protocols, and I asked myself if the epithelium is actually really on, because if you add benzalkonium chloride, EDTA, or a smooth brushing, you will disrupt the corneal epithelium. And if we look at the basic principles, UV light, oxygen, and riboflavin, what happens if we keep the epithelium? Well, an intact epithelium actually reduces the UV transmission by approximately 20%. And if we look at the basic principles, UV light, oxygen, and riboflavin, what happens if we keep the epithelium? In terms of riboflavin, we can clearly see that epi-on protocols have a lower riboflavin concentration in the stroma. And these findings has also been reproduced in other investigations. If we look at the basic principles, UV light, oxygen, and riboflavin, what happens if we keep the epithelium? And we know from prior investigations that the oxygen is highly relevant. If you have an intact epithelium, you have a lower flow of oxygen across the epithelium, and you also have a high consumption of oxygen from the epithelial cells. Altogether, this results in a significantly lower induction of crosslinks when using epi-on protocols. Clinical investigations have shown a high risk of retreatment, especially in children, and systematic reviews have shown that transepithelial crosslinking is significantly safer, but also significantly less efficacious in halting disease progression. But it's just a question of time before we have efficacious epi-on protocols. We need to ascertain that we have a correct concentration of riboflavin equally distributed within the stroma, and we also need to assure the oxygen concentration, possibly by using pulsed UVA and possibly by additional oxygen. We also need more randomized clinical trials to ascertain the clinical effects. Regarding thin cases, there are some different strategies we can use. In a prior investigation, we have shown that you can add sterile water with an osmolarity of 0 during cross-linking treatment. This keeps the corneal thickness above 400 microns, and the outcomes are promising. You can also increase the corneal thickness in thin cases by adding a UV-permeable contact lens during the treatment. A more recent development is the sub-400 protocol developed by Farhad Hafezi and associates in Zurich. This appears to be a physiological treatment strategy where you don't need to adapt the cornea to currently used treatment protocols. Instead, you adapt the fluence according to the corneal thickness. And now to our take-home messages. The first take-home message is that the Dresden protocol is still the most efficacious protocol in inducing crosslinks. All deviations from this protocol will result in a lower crosslinking efficacy. But more crosslinks is not always the best. We know that over-crosslinking can occur with haze and excessive flattening of the cornea. So for the future, we need to understand which is the best treatment protocol for the patient you have in front of you. Regarding epi-on protocols, not yet, but it's just a question of time. It will arrive. So how do we then translate this into clinical practice? Well, this is how I do. Most commonly I use the epi-off 9 mW protocol. It has a fair degree of preclinical and clinical evidence for its efficacy, and it's also time efficient in clinical practice. In children and teenagers, we know there can be a rapid progression, and in these cases I still prefer to use the Dresden protocol. You can use any riboflavin you want, hypotonic or isotonic. Most commonly I use dextran-containing riboflavin. If you don't use the eyelid speculum during the instillation phase, most commonly the corneal thickness is sufficient for a safe treatment. However, if below 400 microns, I commonly add some sterile water to be on the safe side. I believe the next natural step is to use HPMC, where you really preserve the corneal thickness throughout the treatment. So if you use hypotonic or isotonic riboflavin, please check the corneal pachymetry during the treatment procedure. Remember that you can treat thin corneas safely by the sub-400, by using a contact lens, or by adding sterile water. And finally, thank you so much for taking time to listening. If we look at the basic principles, UV light, oxygen, and riboflavin, what happens if we keep the epithelium?
Muchas gracias. Ha sido una actualización muy interesante sobre el crosslinking y pasamos ahora a la última charla, que es por Mohamed Safik desde el Cairo o Alejandría, no sé dónde nos va a hablar sobre técnicas de moldamiento corneal asociadas a crosslinking. Mohamed.
Hello, everybody. First of all, I would like to thank Professor Jorge Aliu for his kind invitation to participate in Alicante Refractiva Internacional. I'm Mohammed Shafiq, Professor of Ophthalmology, University of Alexandria, Egypt. In the next few minutes, I'm going to discuss how to remodel the cornea after corneal cross-linking for a better visual rehabilitation, and to compare this technique with the available techniques in the literature. This is my financial disclosure. As we know, corneal cross-linking does not provide enough good uncorrected visual acuity. And in the best case scenario, we can get to have some flattening of the cornea and some regularization of the irregular astigmatism, as we see in this very good example after 1 year of corneal cross-linking in both right and left eyes. Yet, we have to define our target is to improve the visual performance of the patient. And we know that the visual disability in the keratoconus is mainly due to the corneal irregularity that induces higher order aberration in front of the pupil entrance, as we see in this example. So the logic thing is to address this higher order aberration by a kind of wavefront guided ablation. In the past, our attempts to generate a reliable and repeatable map was a failure due to a low definition aberrometer that we were using. 10 years ago, we started to have in the market high-definition aberrometers that were able to read well the regular corneas with high resolution, such as this example, which is the eye design by J&J. I started to use this one, and I started to dig behind the regular cornea, different kind of irregular cornea, and I published my pilot study addressing these kinds of irregular cornea by wavefront guided ablation, and I published this in the Journal of Refractive Surgery in the year 2015. The success was very good, so it pushed me to improve and refine the protocol of the keratoconic patients after corneal cross-linking, and I started to do the wavefront guided ablation PRK in those cases after corneal cross-linking, publishing it in the Journal of Cornea in the year 2016. This is one of these examples of the treated patient, 24-year-old lady that had a corneal cross-linking 1 year before the presentation. Her best corrected visual acuity is 0.3 with -4 diopter of cylinder. As we see, the cornea is extremely irregular in the center. If we go and read it with the high definition aberrometer, we can read the high exuberant coma and the irregular point spread function. As we see, the aberrometer can generate a sort of irregular ablation profile. Simply, we remove the epithelium with an ammoils brush, and we do a PRK powered by the iris pattern registration that guarantees that the beam of the laser hits the exact point of irregularity, and we terminate it by applying mitomycin C for 20 seconds. The results after 3 months, as we see, is more regularity in the center of the cornea, which was enough by removing only 47 microns in the center of the cornea to improve the uncorrected visual acuity to 0.7 and the best corrected visual acuity to 1, using only -1 diopter of astigmatism, which is a real success that we can give the patient a glasses-free life. We can see here after 3 months how the point spread function is so good, and we removed the noxious coma. Now I have clear guidelines for this sequential protocol that we should not ablate more than 15% of the central corneal thickness. We leave a cornea at more than 400. We can do a selective higher order aberration in case that we don't have enough corneal tissue. We can adopt our nomogram to compensate for the cross-linking tissue, although I don't adopt any, and we should keep an eye on the patient not to have any ectasia progression. In this case, we can do a recross-linking, although I didn't have any of in cases of my cohort. I have now a big cohort of more than 60 eyes followed up for more than 5 years, the mean follow-up period, and we can see that the breaking down of the total RMS and the different components of higher order vision are much better after the treatment. 97% of cases of my cohort kept a vision better than 20, 40 or better uncorrected visual acuity after 5 years of post-operative, which is a very good result to give the patient a glasses-free life. Nowadays, I'm not doing any kind of simultaneous protocol. That means simultaneous corneal cross-linking, neither a topo-guided ablation profile. Since the year 2013, I do first corneal cross-linking. I wait for a year at least, and then I do a sort of wavefront-guided ablation PRK after which. And I have many reasons why I don't do a simultaneous PRK with corneal cross-linking, because a simultaneous procedure make a double insert to the keratocyte, and in many cases we confronted with a delayed epithelial healing. This delayed epithelial healing reported with a combined protocol can terminate into a disaster like scarring or infection, like in this example. Another reason that the simultaneous PRK and corneal cross-linking does not take into account the continuous effect of corneal cross-linking in some of these cases with the protocol, like in this example, that kept on flattening for 6 years to terminate up with flattening of 11 diopters. That means more than 11 diopters of hyperopia, and the only way to treat this disaster is to do a sort of keratoplasty. There is a literature, a lot of publications comparing the simultaneous or sequential protocols, and the majority of them are in favor of sequential protocol, to do PRK after corneal cross-linking because of the better outcome. Also, the topography guided protocols that we can use are not so precise. It's like killing an ant with a sledgehammer. It lacks what's called the cause-effect relation, because the cause is the higher order aberrations due to irregularities of the center, while a wavefront guided ablation profile is more refined to address this kind of problem. The topo-guided ablations also takes or addresses the irregularities of the anterior surface of the cornea only. This will unmaxes the irregularity in the posterior surface, while when we do a total ocular wavefront guided ablation, it will take the summation of the anterior and the posterior surface. And this appears clearly in the work of Bruce Allen. He compared the tissue ablated from an ocular wavefront, a total ocular wavefront, to the corneal wavefront, which is a kind of topo-guided ablation profile, and he found that the topo-guided ablation profile takes more tissue, much more tissue than the total wavefront ablation profile. And lastly, the sequential PRK can target emetropia. We wait to the full effect of the corneal cross-linking, and then we can address the emetropia to the patient. That's why my coherent or the coherent of sequential ablation profile has a better uncorrected visual acuity. The protocol is clearly explained in this nice book edited by Professor Jorge Alió in the year 2017, in which I explain all the details of this protocol. In conclusion, the use of PRK combined with corneal cross-linking can be a very useful tool to modify the corneal irregularity in selected cases of keratoconus. The available protocols vary between simultaneous and sequential use of the PRK with corneal cross-linking. The ablation profile vary between the use of topo-guided ablation profile or wavefront-guided modalities. Sequential protocols of doing PRK after corneal cross-linking seems to be a better alternative than simultaneous one, as it can address precisely the visual rehabilitation after having the maximum effect of corneal cross-linking. The precision of the wavefront-guided ablation profile, that the beam is well guided to hit the exact corneal irregularity and can modify the center of the cornea to a better, more regular one, can remove out the higher order aberration, which is responsible for the degradation of vision, and can give a better visual performance of the patients. And I thank you very much from my hometown, Alexandria. Thank you.
Thank you very much, Mohammed. Thanks very much for your excellent review of these eczema options. And volvemos a disponer de un excelente panel. Jorge, Nico y Ana están, teóricamente Ana no sabemos seguro si está, creemos que sí, pero no lo sabemos seguro. Por tanto, vamos a pasar a la discusión. I would like to say hello to Alice, first of all, and Mohammed and Ingemar. Alice, one quick question. Perhaps I misunderstood you, but why did the Fuchs study stop? The project that you were talking about?
So very sadly for Fuchs, the company decided to suspend the trial because of their financial situation. A completely separate trial they were running for Leber's congenital amaurosis did not meet the clinical endpoints in a phase 3, and that had significant financial implications for the company, and they had to suspend the trial. Not only the Fuchs trial, but other trials they were running for antisense oligos. So yeah, it wasn't any results of the trial itself. We'd only just started to recruit patients, and no patient was yet to be treated.
And is there any similar project on the pipeline already, or not yet?
I'm not aware that there is, sadly. So yes, it gained approval from the MHRA. So the approvals are in place, but I am not aware anywhere currently of an antisense oligo actually being trialed for Fuchs. But the science that we used still stands. So it would be fantastic to see some other companies showing interest in this area moving forward. Obviously, I'm an academic, so we're not going to run the trial without commercial biotech support.
Completely agree. Completely agree.
I have a question for Ingerman. Hello, how are you? My question is, you haven't discussed at all the demarcation line, the role of the demarcation line in the post-treatment, the post-after use of chronic cross-linking. What is the significance, the relevance, and the usefulness that you have in studying the demarcation line by corneal OCT?
I think it's very relevant, but the only problem is we do not know where we can find the crosslinks. I think the utmost point would be to find the crosslinks so we can really show what happens. I mean, the demarcation line is the cell death. So I think it's relevant, but we need to know what happens afterwards. The best biomarker is very complicated to find. We don't have it yet, but I think the demarcation line is of importance. And as we saw in the randomized clinical trial from Hashem and company, they also shown that the demarcation line with high affluences is more shallow. So I think it's of clear interest, absolutely. But we still need to find the most powerful tool in evaluating treatment efficacy.
Now, one other question is about the AP on, AP off. It's clear that we have about 150, maximum 170 with the AP on, but the question is this enough? Because in the study that was performed by Doyle and Stuart Doyle and collaborators in the States, it seems that it was enough to really have an effect on the superficial layers of the stroma, and we don't need to have that deep cross-linking. And so this is, from this point, I think that we need to reconsider probably whether AP-on procedures implemented or not could be an alternative, because it is evident that the early post-op, the recovery time, the loss of visual acuity and the complications are related to the AP-off and not that much to the AP-on, which is quite safe. So what is your opinion, your position about this relevant issue? Because either to use one or the other makes a difference.
Absolutely, it's highly relevant. I think there will be a few studies coming up shortly about the AP-on. I think they will solve the question how to really induce a high treatment efficacy. They will come most likely in the beginning of the year. So I think we're approaching. Well, I think currently to stop the treatment progress, we cannot use them. But we need more randomized clinical trials, because all the problems with the associated pain, infections, haze, etc., I think we need to proceed to AP-on in the future. I also agree that in some patients, we can actually stop the progression and increase the visual acuity. Because if you look at the iontophoresis investigations, they have like a 30% of patients continuing to progress, but the other 70, they have a better visual acuity compared to the Dresden protocol. So I think the Epi-on will be a good future treatment strategy. And I'm so glad that Professor Shafiq also talked about the excimer aspect, because actually, if you just ablate the epithelium when performing epi-off, you get a better visual acuity afterwards compared to ablating it manually. So there are many aspects that needs to be considered. Very good question.
Thank you.
Another question again of course, Nico.
Yeah, I was wondering, when we're targeting a disease like FUTS, that the endothelial cells the same cells are gonna be there like for a very, very long term. So I guess that's easier than if we target a disease of the fibroblasts or even epithelium. Will we have to retreat because will the new cells already have the altered genes?
Yeah, that's a great question. I think you highlight a really important point there. So in terms of developing genetic therapies, I think diseases that originate in the endothelium are potentially better suited or easier targets because those cells are largely post-mitotic and they hang around for a long time. It will depend on the modality of treatment. So I focused a little bit mainly on RNA therapeutics in my talk, and an example of how we could use an RNA therapy for Fuchs. For RNA therapy, however, the RNA is being generated all the time, so you would still need to treat throughout an individual's lifetime. However, if you think about targeting the DNA directly, and I believe this is where the field's going with precision medicine, that could potentially be a one-off treatment. And for something like Fuchs that affects the endothelium, it really is, potentially a viable thing to do. You treat once early in life, and that might be enough. Completely right that with cell populations that are continually renewing, it's much, much more complicated, because how do you go about, a one-off treatment there is just not going to work. I hope that's clear. Thank you for your question.
Mohammed, I would like to ask you one question. I like very much your technique, and I find it very, very useful. My question to you is, how do you select patients for this treatment? Because we have intracoronary segments for cases in which obviously you need to remove the cornea, but which is your profile, the patient profile that you select for this combined treatment?
Good morning, Jorge. Good morning, Jose Luis. It's actually how I do select them. The patients are generally either mild or moderate keratoconus. And now in our modern practice, of course, we have now 20 years behind of selecting well the keratoconic patients and diagnosing them early, because most of them are coming to our clinic seeking for a better vision, and they discover they are keratoconic. So the majority of them now we are confronted with, not in the past, are mild or moderate keratoconus. So after the corneal cross-linking, and I'm glad that Ingmar addressed this, most of them are the corneal cross-linking, most of them have a very good effect in regularizing a little bit the cornea. So afterwards, if the patient is after 1 year at least, because we know that the corneal cross-linking has its effect for a maximum time of 6 to 1 year, 6 months to 1 year, you can, if you can read them properly with the high definition aberrometer, this means that you can generate a reliable and dependable ablation profile. In these cases, if they have enough corneal tissue for ablation, I go and I target for them the emetropia. If not, if they don't have enough corneal tissue, I just remove the noxious coma and the noxious higher order aberration without touching the low order aberration, of course. And in this way, I can leave them with good glasses. And in all of them, the best corrected visual acuity is improved. I mean, either without using glasses, if you remove everything, the higher and the lower order aberration, or you just give them a better, best corrected visual acuity by removing the noxious coma and the higher order aberration. So my criteria is simply, after 1 year of corneal cross-linking, to get sure that the corneal cross-linking has done its maximum effect, I go and read for them the higher order aberration map. If I can read a dependable and a reliable map for these cases, I go forward and do a PRK, a wavefront-guided PRK with mitomycin C.
And when you're selecting the aberrations that you are treating, do you treat also the spherical aberration? Because we treat the coma mostly because to treat the spherical makes the ablation depth to be much more. So what do you do? Only the coma or coma plus the spherical aberration?
Definitely the coma, and if I have enough tissue and I can select properly, if this the spherical aberration is the main cause or the second main cause, yes, I go for the spherical aberration. But seldomly it is the cause. The majority of the cases, if you read them, you will find that the coma is the major cause.
I have a question, if I can.
Of course, Jorge, move on.
Hi, hello. So it's just to continue the discussion with Professor Safik. I think it has been a marvelous presentation. I approach these cases in a different way, and it's just to exchange ideas with you, Professor Safik, to see what you think. So I do always combine in the same day, because already Kenelopoulos proved on a trial doing simultaneous and sequential that the simultaneous did better. And one of the reasons of why it does better is because if you do sequential, it has been proven that the risk of haze is higher. Why? Because in the end, with the cross-linking, you are making a depletion of the keratocytes, while if you do sequential, you are depleting the keratocytes repopulate, and then you do a second aggression that increases the risk of haze. No? It's true that, as you said, the delayed epithelial healing is a concern, although I've seen, talking to colleagues, because it's a treatment I do, I've never had to face a delayed epithelial healing in 6 cases. I have colleagues that they have had to do it, and usually I'm not sure why. It seems to happen in very dry environments, like, for example, here in central Spain. I'm not sure if you work in Alexandria and Cairo, maybe. I'm not sure if you are seeing it more in Cairo than in Alexandria, because in Alexandria, I guess it's more humid. So I guess my feeling is that it has an influence on the environmental conditions for that delayed epithelial healing risk. But if you take that out from the equation, really the evidence goes in favor of the simultaneous approach. And also because even if you have a case like the one you showed with a surprisingly incredible effect of flattening with a +11, this is going to happen even if you do a sequential approach. So the problem, you're going to have it anyway. You're going to have your cross-linking with +11, and then you will have to deal with it even if you do a sequential approach, because in the end, in the combined, at least the way I do, I not approach for the metropia, I go for the aberrations, no? So I'm not sure, what do you think about these sites?
Again, why I did quit the simultaneous procedures were first because of the delayed epithelial healing. And I had them in a very good number of cases that terminated in some of them in scarring, opposite to the common belief that the simultaneous does not cause scarring. No, it causes scarring when there is a delayed epithelial healing. After exhausting, of course, all measures to re-epithelialize them again, and even using the RGTA and the plasma and so on, the plasma eye drops, I mean. So this was the main cause. The second cause that I noted, if you wait for the maximum effect of the corneal cross-linking, the patient by himself reports a very good improvement of his best corrected visual acuity. This means that you have a more regular cornea that allows you a better end result. I'm talking to the uncorrected visual, I'm talking about the uncorrected visual acuity afterwards. And the third one is the flattening, the continuous flattening. And I think this needs to be more studied. I think the continuous flattening in the population of the simultaneous one is much higher than the sequential one, because the continuous flattening might be due to the excessive scarring that we cause because of the insult to the cornea, double insult. And we can't ignore that the PRK is killing to the keratocytes and also the corneal cross-linking. This is based totally on an experience of doing these cases. We have a lot of cases in our environment. Maybe the excess ultraviolet, maybe, of course, the humidity, but Alexandria is humid. But we need to do a comparative study. We're doing it now between the outcome. I mean, it's a retrospective one, to study the cases that had before the simultaneous protocol and the cases that had the sequential one, because we have now more than 10 years. We are calling them back to compare the outcome, the final outcome, who had a continuous effect and who had stable results, who had scarring and who had not. And I think I'll be happy to present the results within the next year to compare between them. It's a big study, a multicentric one between Cairo and Alexandria, and I hope to come up with a good recipe for these cases, because we don't have a common consensus which one is better. Everyone has his own recipe, but from the clinical experience, this recipe gives a very good uncorrected visual acuity to our patients. I hope I answered your question.
With this,
Yes, sure. Thank you.
Thanks very much. Thanks very much, Mohammed. Thanks very much to all of you. We need to close the session. Alice, Ingemar, Mohammed, Nico, Jorge, thanks very much, and hope to see you soon.
Thank you.
Thank you. Bye-bye.
Thank you so much. Bye.
Bye-bye. Thank you.